among social media users in Kenya and Nigeria using behavioral science and chatbots. So my name is Inji Saleh. I am the research lead for labs and academic collaborations at the Busara Center for Behavioral Economics. The Busara Center is a research and advisory organization working to advance and apply behavioral science in the Global South in pursuit of poverty alleviation. Busara collaborated with researchers from the University of Chicago, who are also part of our panel of today's webinar, in order to gain usable behavioral insights to facilitate a deeper understanding of the barriers and attitudes to COVID-19 vaccination in East and West Africa. The study also explores how governments can leverage social media platforms for messaging to improve the policy impact. To this end, the researchers, along with the Busara team, examined whether interventions delivered via a Facebook Messenger chatbot can use COVID-19 vaccination intentions among social media users in Kenya and Nigeria. Now, I would like to welcome the panelists for today, starting with Leah Rosenzweig, Director at the Development Innovation Lab at the University of Chicago. Leah leads several projects across the lab related to vaccine acceptance. She uses behavioral science tools to test interventions to increase vaccine uptake and online experiments to reduce the spread of health misinformation. We're also happy to have with us Molly Offer-Westort, Assistant Professor in the Department of Political Science at the University of Chicago. Molly works on quantitative methodology for social science research with a focus on causal inference, machine learning, and experimental design. From the Busara team, we have Anne Wanjiko, Qualitative Research Specialist. Anne has extensive experience working with both research and advisory clients in a wide variety of sectors, including health, financial inclusion, civic engagement, women empowerment, and governance. Her work at Busara is centered on behavioral foundations, behavioral design, and a mixed methods approach to qualitative and quantitative research. And last but not least, Mary Wawera, Senior Qualitative Analyst at Busara. Mary ran and managed numerous large-scale projects and lab experiments across Kenya, Tanzania, Uganda, and Ethiopia. She has extensive experience working with clients in a wide variety of sectors, including financial inclusion, health, agriculture, and women's empowerment. Her work focuses on creating instruments to measure specific behaviors, as well as running field and lab experiments to evaluate people's behaviors and perceptions. Welcome again to all our panelists. We will now begin with a quick poll for the audience, which will appear to you on the screen. And I invite you to take part by selecting the relevant answers. Perfect. So the first question that we have is, please tell us a bit about yourself, and you can choose all the answers that apply. Would you identify as a researcher, policymaker, vaccine warrior, parent, behavioral science believer, caregiver, healthcare provider, or student of life? And Nenga, if you would like to assist me to show the results. All right, so we have a majority of research enthusiasts, behavioral science believers, and students of life. Great. Okay, the next question is, what are some common myths you've heard about the COVID-19 vaccine? Also, you can choose all that applies. COVID vaccines will affect my fertility and libido. The side effects of the vaccine are dangerous. The COVID vaccine will turn people into zombies after 2 years. Once I receive the COVID-19 vaccine, I no longer need to wear a mask. If I've already had COVID-19, I don't need a vaccine. Or receiving the vaccine will make you magnetic or cause light bulbs to light up when you get close. the common myths that you've heard around COVID-19. Okay, so we have a majority of people answering that if one of the common myths is if I've already had COVID-19, I don't need a vaccine, and that the side effects of the vaccine are dangerous, and that COVID vaccines will affect my fertility and libido. And we also have some people who said that the COVID vaccine will turn people into zombies after 2 years. Right. All right. The last question. What percentage of respondents in Kenya and Nigeria thought COVID wasn't real? Please select one answer. 2% in Kenya and 3% in Nigeria, 80% across both countries, 62% in Kenya, 57% in Nigeria, or 16% in Kenya and 9% in Nigeria. All right, so we have a 50% of people mentioned that the answer is 62% in Kenya and 57% in Nigeria thought COVID-19 wasn't real. So to find out the right percentage, we will now proceed to watch a brief video about the study and its findings. And after we come back, we will have a discussion with the panelists about the research and its policy implications. And then we will take a few questions from the attendees.
Increasing vaccine uptake is a primary concern for most governments, especially as COVID-19 refuses to go away. In sub-Saharan Africa, with rapidly expanding populations, social media is quickly becoming a hotbed for misinformation.
This is why Molly and Leah from University of Chicago partnered with Busara on this study to find out what interventions would increase vaccine uptake. First, we had to understand people's attitudes towards COVID-19, where they were getting their information about the vaccine, how this information was being shared, motivations for vaccine acceptance, and other practical issues around access to the vaccine.
We gained this knowledge by holding focus groups in Kenya and Nigeria. Here's a few of our key findings. First, rumors and conspiracy theories were mainly circulated through online sources. Social media such as Facebook and WhatsApp were the most common sources of information and misinformation about COVID. What's more, the amount of material on these platforms caused an overload, making it hard for users to discern between factual and deceptive postings.
Second, concerns about the vaccine were mainly around side effects. This was based on shared experiences of people who had taken up vaccines, as well as misinformation shared within social networks. Third, vaccine acceptance was higher in older participants than in younger ones. Older participants, particularly those with underlying conditions, perceived themselves to be at a high risk. Meanwhile, the youth's low perception may have been due to the ideas of strong immunity, lack of information about COVID, and doubts over the existence of the virus.
Finally, participants in rural areas face challenges accessing the vaccine. From outright unavailability of the vaccine to inadequate communication and long queues, they faced more barriers than their urban counterparts. We then designed a series of interventions based on the insights we had received. Our interventions were targeted at addressing concerns brought up by participants to see if it increased their willingness to receive the vaccine. Next, we will highlight what interventions are most effective around addressing particular concerns.
For participants who were worried about the side effects of the vaccine, we found that a two-pronged approach works. First, informing them about the normal side effects, which are mild and short-lived. Second, messaging that compares the side effects of the vaccine to the symptoms of COVID-19 showed how much less severe it was to handle a few days of side effects versus contracting the disease. For participants who didn't think the vaccine works, we found it best to present them with material on how to discern between factual and deceptive information. We also found that showing them a photo of a political leader, such as the nation's president getting the vaccine, to be effective.
3% of respondents in Nigeria and 2% of respondents in Kenya thought that COVID-19 wasn't real. Reminding this audience that not everything they see online is true, and asking them to pause and think about whether a post is accurate or not worked best out of the different messages we tried. For participants who didn't need the vaccine because they were protected by God, it was best to remind them of the good times before the pandemic, when everyone could go outside and interact with each other.
We found that showing a video from WHO on vaccine safety and effectiveness worked with the participants that were struggling with trusting their healthcare workers or the government. Finally, for participants who are unsure what to believe, we found it most effective to present them with tips for spotting accurate and debunking false information about COVID-19 vaccine side effects.
We tested this version of a chatbot conversation compared to just providing a standard generic message to everyone, and found that the concern addressing chatbot increases COVID-19 vaccine intentions and willingness compared to both a general public service announcement chatbot and a chatbot that provides no information. These results suggest that rather than using generic messaging, policymakers ought to incorporate tailored communication in order to increase COVID-19 vaccine uptake.
The road to vaccine uptake forks in many directions, and knowing how best to address an individual's concerns is important, as people's beliefs ultimately inform the actions they take.
Welcome back, everyone, and welcome once again to the panelists. I hope the video was helpful in shedding light on the study design and findings. I will now turn to our panel, and for questions from the audience, please post your questions in the Q&A part of the Zoom window below. And if they have not been addressed by the panelists in this discussion, I will either direct them to the panelists in the Q&A section of the webinar, or the panelists will answer your questions directly on the Q&A chat. And if time does not permit for either, then my colleagues will support me in taking note of them, and the responses will be sent to you as part of the follow-up email to this webinar. Now, turning to our panelists, my first question is to Anne. Anne, from analyzing community engagement discussions and looking at the data, what were the most important findings on the attitudes and perceptions towards the COVID vaccine, and how do they differ between Kenya and Nigeria?
Sure. Thanks, Angie, for that question. Before I talk about the attitudes and the perceptions, allow me to briefly describe some of the profiles that we saw from our sample participants. We had a total of 33 participants in Kenya, 40 participants in Nigeria. And from this sample, we identified 3 groups that we think better describe where people or participants lie in terms of their vaccine acceptance. Now, the first group we had were the vaccinated people. In Kenya, 11 of the 33 participants had been vaccinated, and 16 of the 40 participants in Nigeria had also been vaccinated. And that was the first group. This had either received both doses or 1 dose pending the last one. And then for the second group, this was the group that opted for a wait-and-see approach. These are the people who reported that they were willing to take up the vaccine if it was made available, and they did report that they would probably take up the vaccine. These people were likely to be influenced by the vaccine availability and the access. They were likely to be influenced by what they learned about the vaccine, and they were also likely to be influenced by what they had heard from people about the vaccine safety and the side effects. And they were generally concerned about the side effects, both long-term and short-term side effects. And then we had the last group of people who, vaccination was not top of their mind. The resistant group that outrightly said, no, we will not get the vaccine if it was made available or even deemed safe. And these people they were an interesting group in the sense that they did not care much for the expert figures. They reported lack of trust in the government, and they generally felt that they were not at risk of getting the vaccine. And so to understand the attitudes of participants towards the vaccines, we presented participants with 8 statements with a 5-point Likert scale. So 5 for strongly agree, 1 for strongly disagree. And these statements were drawn from the vaccine attitudes examination scale, which is it's a validated scale for measuring vaccine hesitancy. And so what we did is we considered the statements with the highest agreement and disagreement rates as the main attributes, or sorry, as the main attitudes towards the COVID vaccine. From the graph presented to you by Nanga, what we see is that in both countries, safety or side effects of the vaccine was a major concern. However, in Kenya, what we see is that there were some popular ideas around one could still get COVID if vaccinated, and that the vaccination is the best way to get back to normal lives. This is slightly different from Nigeria, where we see a more complicated set of beliefs, where some of the popular ideas were around trusting the government. So the vaccine is a way for the government to get funding, and the government is focusing too much attention and resources to the COVID pandemic. And this is an important finding because trust is critical to vaccine acceptance. We also saw that people's attitudes closely was related to their behaviors in terms of sources of information and their experiences. For example, those who had been vaccinated felt that it was everyone's responsibility to get the COVID vaccine. And they genuinely cared about their loved ones. In terms of their behaviors, what we see is that they were more likely to be the role models for others to take up the vaccine. However, those who were more resistant believed that vaccination was a personal choice. And in terms of behaviors, they were likely to be the ones who flaunted the COVID-19 protective measures, such as wearing masks and social distancing. And I think these findings are very important in terms of their implications when you're thinking about message framing. And we will see this a little later. So for example, those in the wait and see approach could benefit from messages that provide more information about the COVID vaccine, the safety of the vaccines, long and short-term health effects, as well as easy access to these vaccines. Whilst for those who were more resistant, are likely to be more susceptible to being convinced by religious leaders, for example, or other trusted members of the community, certainly not the government for whom they do not resonate with. And I say religious leaders because this is very common, especially in Nigeria, where a lot of the participants reported that we had statements such as, we have not had our religious leaders talk about this, which indicates that taking the COVID vaccine is not safe. And so, Angel, those are just some of the important findings that we saw across both countries.
Thank you so much, Anne. Thank you so much for the useful insights. And I would like to remind our audience, if you have any questions, please use the Q&A part at the bottom of your Zoom window. Now, my next question is for Mary. During prototyping and testing of the different messages, can you also reflect on the most effective messages and how they differed between Kenya and Nigeria?
So thank you, Angie. So although most of the messages that we shared with the participants were deemed as not effective or they were not positive, or they didn't have any positive impact across both countries, there were those messages that were effective for maybe, say for instance, Kenya, there were those messages that were not effective, say for Nigeria. So for instance, there was this particular message that we shared in Kenya, which was saying like, think about what your life was before COVID-19 came. In Kenya, this message, all the participants that we were talking to mentioned that this message was positive and it had some impact on them because they felt that if they could take the vaccine, maybe their life would go back to how it was before COVID-19. But when the same message was shared in Nigeria, the participants all said that it only captured what their life was or their experience was, but it didn't necessarily would make anyone want to go for the vaccine. Similarly, in Nigeria, there was the message that was the most effective for them was, even if you don't think you're vulnerable to COVID-19, by you getting the vaccine yourself, you're helping to protect others from COVID-19. That particular message was most effective in Nigeria, not in Kenya. Reason being, in Kenya, people believe that vaccine does not protect the wider community, because even if you get vaccinated, you can still get COVID, and you still have to wear the mask and sanitize and observe all the measures. However, in Nigeria, people felt that the message was more reasonable and it was appealing to their altruism and can enable respondents to get the vaccine, or can encourage people to go get vaccinated. That same age, there were also messages that were taken as positive across both countries. For example, a message that was speaking more of doctors and medical professionals. People who are in both countries, they had a high level of trust of professional or health professionals, because they always feel like they are the first people that people run to in case they have any health issues, or even if they're at risk of anything. So any message that had anything to do with health professional was taken positively, or people feel that it was effective. So those were some of the findings that we found about the messages.
Thank you very much, Mary. That's very interesting. And learning the differences in reaction to the messages between the two countries is very insightful as well. Thank you. Now turning to Molly. Molly, can you describe how you used the qualitative findings to inform the quantitative part of the study, and how the researchers learned what messages worked best to address each concern?
Yes, absolutely. Thank you. So in those focus group discussions, as Anne and Mary discussed, we learned that even though people were fairly knowledgeable about and aware of the virus, there were also a number of these factors that were contributing to vaccine hesitancy. So in addition to the focus group discussions, we also ran a pre-pilot on Facebook that was a short open response survey among respondents in Kenya and Nigeria, to also ask them online and see why people there said that they were hesitant to get vaccinated. And so we saw similar areas of concerns. People were concerned over side effects. There were questions about the vaccine safety and effectiveness, and belief that the vaccine is not necessary because COVID-19 might not pose a serious threat in actuality. So we combined these findings into the main categories of vaccine concerns. And you can see in this figure, is this figure showing? Can I get a thumbs up from the panel? Yes, okay. So you can see at the top here, we have these main categories of user concerns. So based on our online pilot and on these in-depth focus group discussions, we developed these different categories of concerns that people might have about the COVID-19 vaccine. So one, people were worried about the vaccine side effects. People also didn't think the vaccine works to prevent COVID-19, that they didn't think COVID was real, that they didn't think that they needed the vaccine because they were protected by God, and so on. So these are all the categories that we allowed people to select from. And then we had our set of messages, which you can see below this. And these messages, as mentioned by Mary, were prototyped and tested in our focus group discussions based on what people said that they would be receptive to, or what types of messaging made sense in these contexts. So what you see below here in these messages are short forms of these messages. It just gives you an idea of the different types of messaging that we looked at. But so for example, we had some messaging around how vaccine side effects are actually mild. We had in the second row here, debunking vaccine side effects. So based on some specific rumors that people had mentioned in these focus group discussions, we particularly addressed those types of messages. And then we ran a learning study on Facebook, so a larger study on Facebook among respondents in Kenya and Nigeria who had not yet been vaccinated. So we recruited people online on Facebook, and we had conversations with them on Facebook Messenger via our chatbot. And so we asked them in those conversations amongst these people in Kenya and Nigeria who had not been vaccinated, what their main concern or question was around the vaccine. We allowed them to select from these categories. And also in our learning phase, we had an open response category so people could tell us other concerns that they might have. So we could see if our categories are actually comprehensive. And then we delivered them one of these messages that was related to their concern. So you can see based on the coloring here, the different messages that are associated with each concern. So each of these messages here that have a red box in the bottom of the message were sent to people who said that they were worried about the side effects of the vaccine. And in this learning study, we used an adaptive experimental design. So this is a type of experimental design that I work on, where we update the messages that we might show to people based on which messages were seen to be most effective. So we asked people what their concern was, they told us what their concern was, we showed them a message related to that concern, and then we asked if that addressed their concern. And so based on whether people said that a message addressed their concern or not, we were more or less likely to show that message to other people. And this led us to learn more quickly which messages were most effective. So we selected which messages we showed to people in this stage of this experiment, and then we'll talk a little bit later about the efficacy of this approach to addressing messaging.
Thank you so much, Molly. Thank you very much for expanding and elaborating on the experimental design. That was very helpful. My next question is for both Leah and Molly. If you could elaborate more on the main quantitative results and also reflect on the policy implications from the study.
Great. Thanks, Angie. I can start. So as Molly described, in the learning phase, we evaluated and found the most successful messages depending on what people's concerns were. And so then we wanted to evaluate how well does that concern addressing chatbot perform in terms of increasing vaccine acceptance compared to two other arms. And as Molly's showing you on the graph here, the first arm was a control arm. So we provided no new information about the vaccine to participants, but they interacted with a Facebook Messenger bot just to answer some survey questions. The second arm was a public service announcement, or PSA arm, where participants interacted with the Facebook chatbot, and then were provided some sort of generic information about the safety and efficacy of vaccines. This was not personalized or tailored, but mirrored what many governments in Kenya and Nigeria included are trying to tell citizens about the vaccine to encourage uptake. And so as you can see from the graph, when we evaluate these three different experimental arms, which participants were randomly assigned to, on the basis of both their stated willingness to get the vaccine and intention to get the vaccine, we created an index. You can see that the concern addressing chatbot in the third column performs better than both the control and the PSA chatbots in both countries, Kenya in blue and Nigeria in yellow. And so we think there are several policy implications for these results, and I'll turn it over to Molly to mention a few.
Thank you. So we think our findings are relevant for policymakers who are trying to quickly and effectively communicate with people about public policies and services that might be available. So this is something that's particularly pressing in a public health crisis when governments are trying to roll out programs very quickly, but this can apply, I think, much more widely when governments are trying to communicate to people, and it might not be easy to address people in all areas, especially in a media environment where there's a lot of misinformation or new confusing information, and it can be hard helping people to sort through that information. When people have questions or concerns, they have a hard time navigating that information online, and so an alternative would be having one-on-one messages with healthcare providers. This is obviously the best course of action when people are concerned about the COVID-19 vaccine, is to talk to their healthcare provider. But that's not directly scalable, and people maybe aren't having those conversations very frequently. And so it can happen that misinformation and disinformation can move very quickly through the population. And so when governments can address these concerns online in a personalized but automated manner, that can allow policymakers to reach people very quickly and address their concerns directly. Additionally, we use this adaptive design that allowed us to quickly learn the most effective messaging, which again is really essential in a fast-moving public health crisis. And I think adaptive designs have a lot of potential for policymakers. The really nice thing about these types of designs is once you learn that a message or an intervention is not effective, you can stop assigning that message to people. And so policymakers really don't want to give people interventions. They don't want to show people messages that they know are not going to be useful for their goals, that they know they're not going to be helpful to informing people and help them make good decisions. And then we had this combination of the qualitative and quantitative work in the study. So the qualitative work was really essential in terms of understanding the context that we were working in, understanding what concerns people actually had, developing messages that would make sense for them. So we could have used a really nice quantitative design where we had this adaptive experiment that we selected among messaging, and we rigorously evaluated the differences across types of interventions. But if we had not started with good qualitative work, our messages might not have been very good at all. And so we could have selected amongst messages, but if the set of messages that we had was not going to be effective or helpful, then we wouldn't have been able to learn the most effective treatments truly. And so this type of mixed methods research design, I think, is very, very important for a lot of policy relevant research.
Thank you very much, Leah and Molly. Thank you. Thank you very much for those important findings and implications, specifically for our attendees from the policymakers and practitioners. A reminder once again, if you have any questions on the research or the findings, to please write your question in the Q&A part, and we will address it in the Q&A section of the webinar. Finally, Leah, every study has its limitations that present opportunities for future research. Can you elaborate on the limitations of the study, and accordingly, what further questions could be explored building on this research?
Yeah, definitely. This study is not without limitations. So there are a couple that are worth highlighting. The first is that we don't have a nationally representative sample, right? So we recruited, both for the qualitative and quantitative aspects of the research, social media users. And we know that social media users, and from some of my other work, tend to be more urban, better educated, younger than average citizens in these countries. We also screened for people who had not yet gotten a single dose of the COVID vaccine. So that, I think it's still the majority in both of these countries, but it's changing, and it is a particular sample of these populations. And so we should be aware that the people in our sample may have quite different concerns or driving factors that explain their lack of vaccination compared to others in these countries. I also want to be clear that we focused this study on concerns and kinds of information interventions that we could manipulate in an online context, and that we could try and move people's attitudes towards a more positive view of COVID-19 vaccination through these online interventions and messaging. And that's by no means to minimize the other barriers that people have to COVID-19 vaccine, whether that's access barriers or things like that. And then finally, I want to mention that the main outcome so far that we've analyzed is this self-reported intention and willingness to get the vaccine. And of course, if you're a behavioral science enthusiast in the audience, you know that there is this intention behavior gap. And so we're trying now to work with some of our collaborators in the government in both countries to get access to administrative data so that we can actually evaluate as well whether or not these online interventions had any actual offline behavioral impact. And so that would be very cool. In terms of future research, in addition to the areas I mentioned, so thinking about more representative samples, coming at this problem of vaccine uptake from all the different angles, we think that there's a ripe opportunity for these kinds of academic policymaker collaborations, meaning that, you know, we took out Facebook advertisements, offering people some small amount of airtime if they participated in an academic study. And we ran this through our Facebook page. And we could imagine that people might react very differently, or it might have a different kind of impact if the organization or person running the study was an actual Ministry of Health Facebook page or website. We've seen these kinds of healthcare chatbots cropping up now, especially around COVID. So the WHO has one, other organizations are running them. What we've seen less of is evaluating how well these chatbots do at changing attitudes and behavior. So we'd be really keen to see more governments and other sort of policymakers moving into this space. And if anyone's interested in collaborating, please reach out to us.
Thank you so much, Leah, for this reflection. And I think it is very important to have this collaboration between the academic field as well as the practitioner and the policymaking field, especially for something, as you mentioned, that is very based on practice and based on the availability of social media platforms. In the end, I would like to thank very much our panelists for sharing those important insights from the research and its applications. We received a couple of questions from the audience that I would like to direct to the panelists. So the first question is, if you can provide a little more information on the locations and the geographic spread of the study participants.
Anne or Mary, do you want to start with the focus group participants?
Sure. So for the qualitative study, we recruited participants from both rural and urban areas. In Nigeria, this was within the local government areas. So the rural regions we focused were Ikorodu, and in the urban region, we focused on the areas Ikeja and Kosofe. And then for Nairobi, we recruited urban participants from our Busara database. So we have a database of participants from which we invite for studies, and these are mainly from Kawangware and Kibera areas. We have a pool of 80,000 respondents, and we had a criteria for which we recruited these participants. And then in the rural areas, we focused on two regions. This is Gikambura area and Kiambu. And for this, we mainly used community mobilizers. So we trained the community mobilizers on what the research study was about, what the criteria for recruitment was, and then we drafted a recruitment script for them to facilitate the recruitment process. And that is how we identified our sample.
And for the quantitative part of the study on Facebook, so as we mentioned, we recruited respondents who were living, or at least Facebook thinks they're living in Kenya or Nigeria, that they're 18 years or above, and took out these ads targeting, these whole countries. And as I think I mentioned before, some of my other research, particularly in Kenya, has shown that people who are on Facebook and those who are willing to click an ad and take a survey, an academic study, tend to be younger, more educated, more urban than the sort of like average citizen. We haven't yet explored very deeply who specifically our participants are and where they are geographically, but that would be my expectation, and it's something we're going to look into.
Thank you very much. Thank you, Anne and Leah. The second question we received relates to what you mentioned, Leah. So the question is, how are you engaging with policymakers from government with these results, especially seeing how slow the government ship turns?
Yeah, let's not put all the blame on government. The academic ship also turns very slowly. So we ran this study, I think, starting in January, and we are now almost at the place where we'll have a policy brief ready to circulate to our government contacts in both countries. I think the plan is that we would circulate those, make them public, reach out to particular contacts we have as well, and probably offer to do similar sort of webinars or live presentations of these results and have conversations so that we can make sure that these results are shared and are as accessible and useful to those policymakers.
Thank you, Leah. Thank you for that. Does anyone from the panel want also to comment on any of the questions that were mentioned? All right, so now we've come to the end of the webinar. I would like to thank our panelists once again and to thank the audience for taking part in this webinar. We hope you were able to benefit from and enjoy the discussions on this timely topic. And if you'd like to know more about Busara's work and upcoming events, please follow us on our social media accounts. You can find us on Facebook, Twitter, Instagram, and LinkedIn. And please follow our blog page on Medium. And I hope you all have a great evening. Thank you very much.
Thank you, everyone. And thanks to all of the panelists as well.
Yeah, thank you all. And thanks to Busara for organizing. This is great.
Yes.